My name is Dr. Amod, and I work as a pain management specialist at Max Hospital. I've spent about 15 years training in UK in different modalities and related to pain management, and now I'm based in Delhi. So the topic today is not just post-operative pain management, but pain management as a whole. The importance of pain, why we're talking about it. It'll all be covered. I think the reason we are talking about this is because most people have got very misconceived notions about pain management, and it's important to address them. And unless the doctors are aware of what we do and what's in the offering, other people's and the patients would not actually know. So the topic is pain management, new horizon. This is the layout of the talk which we are going to be going through today. I will just talk about why talk about pain, then some newer modalities or newer treatment options, newer things which are now a reality. And that's so the whole idea is to cover pain management in terms of various avenues and options available. And starting with that, why talk about pain management? I'm not sure if many of you know that pain is actually the problem of pain is more than if you combine the heart, the cancer, and the diabetes. These are like kind of big problems which we hear about all our life. If you combine the number of people suffering with all these problems together, the number of people suffering with pain issues is even more than that. On an estimate, approximately 20% of the people worldwide have got a chronic pain or a pain issue. And that's why this is important to talk about it. Not only there is a huge prevalence, but also every year 1 out of 10 people is added to this list. So not only is there a big prevalence, but also there is continued addition to this list. And if we just talk about one problem of back pain, did you know that 7 out of 10 people or 8 out of 10 people would have back pain or would be troubled by back pain at some point in their life? So that hardly leaves anyone, and that's just one thing we are talking about, the back pain. And as you age, the chances of you having some pain issues increase. And we all know that the life expectancy all over the world is increasing because of the various reasons, including the medical progression we have had. And some of these people who are suffering from pain are suffering from such severe pain that they actually say that, it's better not to be alive. So hence the importance of talking about the pain. So talking about the misconceptions, this is not just in the general community, but also in the medical community. Like simple things like a lot of people think that all pain management specialists are anesthetists. Yes, I am also an anesthetist, but that's not true. I know of so many neurologists, so many orthopedic doctors who are just doing pain management job. And so it's not just limited to anesthetists. Then a lot of people think that pain management is all about nerve blocks, and this includes very good, well-esteemed doctors I know of who think that, oh, they send me a patient saying that, Amod, can you do a nerve block for him? And they fail to understand that nerve block is a small thing in the whole gamut of pain management, or an epidural is a small thing, and there are many options, and we've progressed much beyond those things. Then another misconception which I see commonly is that when people can't find a source of the pain, they say, oh, it's the person suffering from it is actually got it in their head. So there is a psychogenic cause, or they label it as fibromyalgia. Now, both of these things, just because you can't find the source of pain, I don't think that's right. I'm not saying that pain cannot be psychogenic. I'm not saying that fibromyalgia does not exist. But if you can't find the cause of pain, you label everyone as psychogenic or having fibromyalgia. That's not done. So these are the common misconceptions which I see with people, and the spectrum of options we have to treat different pain condition is increasing, and day by day. And I'll give you examples of this. The expansion is so much that it's hard to keep pace with it. So we were talking about the prevalence of 20% and increasing incidence. So look at this list of pain conditions. You know, just see people around you in your family. How many of them have elderly have got knee pain? How many of even the young people suffer from headaches or back pain? And I'm not talking about other rare conditions like pelvic pain, or post-operative pain or trigeminal neuralgia, which are not actually rare, but relatively rare is what I meant. Cancer pain, simple things like frozen shoulders, plantar fasciitis, tennis elbows. All these are so common, so common that if you just look around you or even analyze people in your family, you will understand what I mean and how common these things are. Now, when we talk about pain, some things seem more painful than other. Like the guy you see on the screen, I'm sure everyone would be thinking, "Oh man, that's gonna be sore." Some people make more noise than actually the pain they have, but that's also a part of us all being different. Then there could be other forms of pain like the mental trauma and agony which one has to go through in various situations, and I'm sure we've all experienced these at some point in our life. But talking about the real pain which we treat, as in like the physical pain, we all know the definition. We all know what it feels like to be in pain. We've all been there at one point or another. So I'm just going to focus on, actually, this topic is very, very vast. So doing justice to it is not very easy. And what I'm going to focus on is on special modalities or special things or special treatments which we as pain physicians do, which you may or may not be aware of. So I've divided them into different headings. One option I would talk about is radiofrequency ablation. The other option I would talk about is cryoablation. Then I'm going to talk about regenerative medicine to a limited extent, which is now taking over a lot of things, and probably future has got great potential for this to expand even further. Then I'm going to talk about diagnostic scans and injections, which we as pain physicians do very often, and the comprehensive approach to pain management and the stronger or the newer analgesics which are available. So these are the broad five headings, and I'm sure you will find very interesting cases in between. It was very difficult to do justice to this whole topic. So what I decided was I will talk about some interesting case reports, which will not only keep you guys engaged, but also would give you a practical idea of how the pain management is expanded and how we can help people, or what are the options available. So let's talk about the first thing. The first thing is radiofrequency ablation. Radiofrequency is a technique. Ablation means to burn, or to ablation means actually to destroy something or to burn something. So in a sense, what this technique employs is it uses the radio frequency to burn or heat an area to an extreme degree to make it dysfunctional, and that's the whole treatment. So let's talk about a few cases which we came across and which we have used this option very effectively. So the first thing I talk about is a case of an 11-year-old child who had congenital long QT syndrome, essentially a condition which predisposes him to arrhythmias. And he was admitted in our hospital, and he was having recurrent VT episodes. Despite full management, medical management, and other interventions, this could not be managed. One of these episodes led to a cardiac arrest where he was down for 10 minutes. He had effective CPR and was revived. They tried everything what they could for him, gave him all the medicines they could to control his arrhythmias, to support his blood pressure, did pacing, gave him 100% oxygen with mechanical ventilation because he was that unwell. And the hour before I went to treat him, he had had 38 shocks to treat his arrhythmias. And it was seeming like a very hopeless situation where everyone was convinced that he's not going to survive. And we were called in to burn his stellate ganglion. Now, stellate ganglion is a structure in the neck, on the side of the neck, which is formed by the lower cervical and upper thoracic ganglion fusing. And this ganglion provides sympathetic outflow to the heart. And so a lot of the signals which pace the heart or cause sympathetic stimulation travel through this ganglion. So what we did for him was, because he was so unstable, he couldn't be moved, on bedside, under ultrasound guidance, we burned that stellate ganglion by radiofrequency ablation, which means that we made it dysfunctional. So this was on day 0 when we did his radiofrequency ablation. Day 1, which is the next day, I couldn't go to see him because I wasn't in the hospital. I was away of the hospital. Day 2, I went to see him, and I remember, you know, uh, walking into it thinking whether he would have survived or not, because he was so unwell. And when I walked into, this is by the way, what I've displayed now is a Facebook post I'd made at that day when I saw him. When I went in there, I saw somebody lying with a blanket, and he's only an 11-year-old, but he was a tall guy. So I saw him, somebody lying in a blanket, and I thought he must have passed away, and probably this is the next patient who has come in his place. And then he took his blanket off, and my eyes suddenly lit up. That was that was the same old guy, this 11-year-old. And not only was had he survived, he was off all blood pressure medications. He was off the ventilator and almost ready, like nothing has happened to him. So I'm like, this is not just pain management we did for him. This is like, like saving a life. So this is how the pain management and the techniques we use is expanding. And this is not used very extensively all over the world, this technique of burning the radio frequency ganglion. So I thought that was a very important one to include as a case report to show you how the pain management guys can help in different situations. And it's not something we were experimenting on. It is a well documented technique, although not used very often, but it is well documented. And if you wanted to read more about it, this paper would give you a nice, this would be a nice one to read. And this is an example of the case report which has been published previously using this technique to save someone else. Anyways, so let's move on to another example of radio frequency. Now, this example is an 87-year-old lady, and she had very limited mobility because of a simple problem that she's got a knee arthritis, and she went to an orthopedic surgeon who for a knee replacement, but unfortunately her medical comorbidities made her unfit for having any surgery. So what we did was we did something called radiofrequency ablation of genicular nerves. So genicular nerves are the nerves which supply the knee joint, and we burned these nerves. So when we burn these nerves, the pain signal originating from the knee joint can't reach the brain. And when they can't reach the brain, the person doesn't feel the pain or it is reduced significantly. So that is what we did. And all she wanted was to be mobile in her house to deal with her daily chores and whatever was required. And she was able to achieve this without having this surgery. She got what she wanted. So moving on to another example. Now, this is another example where we use radio frequency effectively. The guy had a pancreatic cancer, not very old, 54-year-old. He'd had something we used to treat the pancreatic cancer is called celiac plexus block. So he'd had a CT guided block of that area to reduce his pain, but that hadn't worked. So the main nerves of this celiac plexus, which controls innervation to the whole of the upper abdomen or the majority of the abdomen, the main nerve of this plexus is the splanchnic nerve. So what we did was we burned these nerves using radio frequency, and that was effective in reducing his pain. Now, pancreatic cancer, as we all know, is very painful, very nasty, and most of the time, people, depending on what type it is, it can be associated with high mortality rates. So that was it's very important to give effective relief to these guys who've got maybe a limited amount of lifespan remaining. And the same treatment we sometimes use for chronic pancreatitis as well. And I've treated so many young people with congenital problems who've got chronic pancreatitis, and they end up in the hospital every month or 2 months time because of the pancreatitis flare up. To control their pain, we can burn these nerves, which can give them relief, sometimes very long and very significant relief as well. So that's also an effective treatment, an example of how we use radio frequency. Now, so that's a few examples of saying how burning of the nerves, which we could never even think of, to as high as 80 degrees can be effective in managing pain. Now, let's look at exactly the opposite. What about freezing of the nerves? If the burning of the nerves works, does freezing of the nerve also work? So this is an example where we used freezing of the nerves to help people. So there was a 61-year-old male, and I'm using his picture because he's given us a review which is available on YouTube, which any one of you, if you wanted to see, you can see it. So he had a accident and a road traffic accident, and he got multiple injuries, including multiple level rib fractures. And they were so painful that he couldn't be weaned off the ventilator because the pain would stop him from breathing. And I know in this picture, he looks like a normal, healthy person, but when he had this injury, he was at least 20-30 kgs more. So this is when he's lost weight. So at that time, the obesity and the combination of pain and the broken ribs were not letting him come off the ventilator and breathe properly. So what was done for him was they surgically fixed his ribs, and we froze his intercostal nerves, which are the nerves which supply these ribs. And once you freeze them to minus 80 degrees, now minus 80 degrees, who could imagine that we could freeze nerves in the human body to minus 80 degrees and relieve someone's pain? It sounds like something from science fiction, but no, no, no. This is actual treatment we do for people. So we froze his nerves. It took us a long time to do all the procedure, and within 2 days he was weaned off the ventilator. Within a week he was discharged home. So these are obviously success stories which I'm sharing with you. But this is how the technology is advancing and how we are helping people to get better and get home and get what they want. This is another example where I'm doing a procedure on a lady who's this is just after COVID. This lady had Parkinsonism, and then she had bilateral shoulder arthritis, and she got COVID and then got bedridden. The problem was that because of her shoulder arthritis, she couldn't lie on either side, so she was always lying supine. And when she was lying supine, she developed bed sores, and they were very painful. So she was admitted under the plastics team, and they wanted that she should be able to lie on the side so that, after the debridement, the bed sores can heal. And the lady actually wanted that her shoulder pain should go down a little bit so that she can actually eat and drink on her own. So what we did for her was did cryoablation, which is the freezing of the nerves which supply the shoulder joint. Now, obviously, she's too unwell to have any kind of shoulder replacement, and that too bilateral. So we froze those nerves which were supplying the shoulder joint to give her relief. And with that, the next day when I went to see her, she was doing this to me. She raised her hand above her head, which was like a dream for her, just to raise her hand to have a cup of tea or eat. And she could lie on her side. So this is how cryoablation helps. It works almost immediately, and we could relieve her of her pain and help achieve the medical team and the patient what they wanted. So this one, again, this is a very interesting case. A young guy who had an ingrowing nail in his finger, and then one thing led to another. And he had, by the time he came to see me, it had more than 10 surgeries. He told me that I've had more than 250 injections to relieve the pain from this finger, and after that, I stopped counting. So every time you would go to someone, they will put in a ring block, which is like a local anesthetic or a steroid block around the finger, which controls all the nerves, which supplies to the rest of the finger, and that would give him relief for a short duration. And he was a student, so all he wanted was, he said to me, "Listen, I don't care if you remove the finger. I just want to, that this pain should settle down so that I can carry on with my education and my normal life." So anyway, so what we did was, with the help of ultrasound, we looked at the digital nerves. They're very tiny nerves, two on the dorsal aspect and two on the palmar aspect of the finger. And then we used very tiny amount of local anesthetic to see which of these four nerves was actually carrying the pain impulses majorly. So we blocked these nerves in a sequential manner, seeing how much of the pain score comes down. And then we went on to, so this is actually the image of this is the nerve, this is the needle or the cryoprobe which is coming in. This is again the nerve overhead marked with an arrow, and then the star shows the needle coming in. So we froze. This is actually the picture of the treatment being carried on, and this is him after the treatment. Um, and if I show you the video, his finger was moving perfectly fine. His pain score came down significantly, and he was happy with that. So you can see the marks of the treatment on the palmar aspect and on the dorsal side as well. It is like a frostbite on the dorsal side. But you can see his finger function is retained, so he didn't have to chop his finger off. And we could help him by reducing his pain and carrying on with his education. So this is how a cryoablation machine looks like, which is shown on your screen now, and you can see the temperature on it reads as minus 78. So freeze time is ongoing. So this is taken while we are doing a treatment, and you can see the gas flow is there. We use a special gas to run through the machine. So this is actually a picture of the machine while the treatment is being done. So we used it for another patient who had cancer pain. He only had a very short history of 2 weeks where he was admitted with the hospital with severe pain, and they found when they did a scan that there was a lung mass which was invading onto the intercostal nerves, and he was getting chest and abdominal pain. So we again froze this nerves, and he had a comfortable life. I'm not saying he was pain-free because the tumor was really big, but he had a comfortable life till he passed away a few months later. So this is how we're using the technology, and actually the newspapers like this, what we had done, and they actually published it. It was even published in the newspaper because it hadn't been used that often before this for this purpose. Anyways, so this is how we've used cryoablation. Now moving to another topic, regenerative medicine. Tiger Woods is who made it famous when he had treatment with PRP. And since then, it is being used for everything from growing hair to genital organs, from polishing the uterine lining to the facial lining. It's been used for multiple purposes, but it has a role in there. And if used correctly, things like regenerative medicine can offer a lot. And the whole idea is it's always fascinated human beings to have find a way where we can grow back into our younger years. If you've seen the movie Indiana Jones movie on this, the Raiders of the Lost Ark, you would know what I mean, where they're searching a fountain of youth. But again, it's this PRP treatment, the growth factor concentrates, all of these are very commonly used for things like arthritis, tendon tears, rotator cuff tears, plantar fasciitis. All these conditions, they get excellent results when we use growth factor concentrate or PRP. And now what is coming in significantly in a big way is stem cells. And I'm sure this is something which will be available to more of us with more of indications in the future with a huge potential. There's a lot of research going on it, and we are all looking forward to how it can help us in terms of curing, uh, not curing, in terms of regenerating and restoring things rather than, thinking that things are not curable or incurable. So that's just a little brief about the regenerative options. Now, I'm going to give you a few examples on how we use ultrasound and other diagnostic modalities. Now, ultrasound is one thing which has actually changed the way how pain management is being done, because it provides an effective bedside tool which can help us in so many ways, not only guiding our needles and performing injections accurately and reducing complications, but also in diagnosing things. I'll give you some examples and you'll understand what I mean. So this is an example of a condition called ACNES, or anterior cutaneous nerve entrapment syndrome. So to give you an example, I had a lady who had abdominal pain and she had a gallbladder removed. She had her uterus removed and the pain would still be there. And we see a lot of these people who have similar pains where we can't find the cause. And actually, in this case, the problem was in the nerves as they come out of the rectus muscle. So the intercostal nerves, when they travel through the chest, they travel all the way into the abdominal wall, as shown in this diagram. And then they go through the rectus muscle to come out to the anterior border. And the corresponding image on the right hand side is actually showing the nerve, which is marked with an arrow traveling through the rectus muscle. So these nerves, they can get trapped inside the rectus muscle. And when that happens, that can lead to pain. So all abdominal pain is not coming from the viscera, but the abdominal wall, like the chest wall, can also be a source of pain. And these nerves can get entrapped and cause pain, which is often not diagnosed. With the help of ultrasound, we can not only, pinpoint these nerves accurately, but also perform injections. And if you inject on these nerves or close to these nerves and the pain goes away, then that's a very simple test of telling you the pain is actually coming from the abdominal wall and not from inside the viscera. So there's no need to remove any organs inside. And that's how things have progressed and our understanding has changed. So we published a case report on a lady who just got actually an abscess in her tummy, very superficial one, and the nerve got entrapped, and she went through so many operations. And actually, the cause was in the abdominal wall, and when we treated that, that all got better. So another example of how we've used ultrasound. So this lady, as you can see, she had a simple hip fracture after a fall, and then they did a replacement surgery, which again had some complications, and the implants didn't stay in for long. Then she developed injections and had 5 surgeries. And when she came to us, she had such severe pain. She'd had 5 surgeries. No surgeon was ready to touch her anymore because The anatomy was so deformed and she was in severe pain. So all what we did for her was ultrasound guided block of the lateral cutaneous nerve of the thigh, which is the condition called neuralgia paresthetica. And her pain improved by more than 50%. We were actually looking for the bursa also, because often in these patients, the bursa is the source of pain, but the anatomy was so distorted that we couldn't find it. But her pain, actually more than 50% was coming from the lateral cutaneous nerve, which we sorted out as an OPD procedure. So despite 5 surgeries, she was left with so much of pain, which we made 50% better by just doing an OPD procedure. So that's how the ultrasound is helping us. This is another example where a patient underwent a hernia repair, and after that he had severe genital and testicular pain. And when we did a diagnostic ultrasound, you can see how the mesh is looking over there. And then there was a seroma formation, which is very nicely depicted in this other picture, with the somatic cord being pushed to one corner. And all we did was injected in this area a steroid and local anesthetic, where the spermatic cord was close to the seroma, and the pain reduced and he could be discharged. And he was in the hospital post surgery just because of this pain for so many days. One injection and he's able to go home. And not only did we do the injection to relieve his pain, but we also found what is happening. So this is how the diagnostic scanning is being used by pain physicians to give you an accurate diagnosis. These may have had multiple CT scans, MRIs, but these which I'm showing to you now were a liver, donor, all our belly, and we could very clearly visible on the other image. If you see that white area just above the dark black shadow, and that was removed and the pain was better. So this is how the ultrasound helps us, um, in diagnosing these problems which may not be diagnosed by other investigations. Now, there are other multiple issues which nobody talks about, like genital pain, pudendal neuralgia. Now, all these things, they can be diagnosed, they can be treated, uh, thanks to ultrasound and thanks to our understanding and thanks to the advancement, especially the things which fall between specialities. Like any pain in the pelvic area can be an orthopedic issue, can be a colorectal issue, can be a gynae issue, can be a urological issue. So all these things where there are multiple specialities involved, often things fall through the net, where by which I mean the diagnosis may not be easy, the diagnosis may not be accurate. Often we end up saying, oh, the pain must be in your head. And this is where pain management comes in, because it unites all these specialities, helps to find the cause of pain and treat it appropriately. This is another example. So this patient, this is actually an ultrasound image of an forearm. So this patient was sent by a neurologist saying that he's got tennis elbow. Can you please do an injection for him? And we put the ultrasound probe on his area, and there were some small nodules kind of thing which we could feel. And what you see, these nodules, the black area in between the parallel fibers, these are actually, the lesions of cysticercosis, where in the middle of the lesion, what you see, the black area is the scolex. And this is a very typical appearance of this condition. And actually, the patient didn't have tennis elbow, but what he had was cysticercosis. We offered him to do a brain scan, because if there is a peripheral lesion, then there is a good chance that there would be a brain lesion as well. But he didn't want to go ahead with it because of financial reasons, and he went on empirical treatment. But you can see how the treatment actually totally changed from doing a tennis elbow injection to actually treating cysticercosis, which may have other serious implications if you had brain lesions as well. So there are other things which have developed, like for frozen shoulder, there was a time when people would be put off to sleep, as in like given general anesthesia. and their arm would be kind of stretched to extremes because we wanted to break the adhesions of the capsule, the shoulder capsule, which is the basic problem in frozen shoulder. Now, with ultrasound, what we do is we distend the capsule. So with ultrasound, we can see the capsule, we go below it, we inject water or local anesthetic or steroid or whatever we want to and stretch that capsule. Sometimes we even see it breaking like a pop, which is what we used to do it with surgery before. And now all these things can be done in the OPD without admitting the patient, without actually having them to have a general anesthesia. Things like calcific tendonitis, where you get calcium deposits in the rotator cuff. Now we can, just break those calcium deposits under ultrasound guidance very accurately and absorb them back by doing OPD procedures, which was previously a surgical thing. So this is how the syringe you see, it's all whitish in color because of the calcium which is dissolved in it and come back. So timely diagnosis is very important when you deal with pain conditions. Pain just does not mean acute pain, which we see after injury or surgery, but also chronic pain, which stays in for a very long time. Because if the pain persists for a long time, then people start developing fears, they start developing inhibitions. They have their own psychological impact where they kind of think, oh, I need to rest because it's hurting, I don't need to use it. And they start avoiding movements where the muscle fatigue sets in, the muscle atrophy sets in, which we call as deconditioning. Then they start getting fixated on, oh, I have to take that medicine, otherwise I won't get better. So there's a lot of things which come in with time. So timely diagnosis when you're dealing with pain is very, very important. And the treatment cannot be just with interventions. You have to look at the whole gamut of things. You have to address the psychological causes where they are. You have to do the procedures or interventions to give them relief where necessary. You have to use the right medications to give them relief and put them back in control. And then when the pain is going down, you start with strengthening and physiotherapy to kind of, put the muscles back where they should be or condition them as they should be. So this is just a brief about myself. I've told you how interesting the field of pain management is, but I started as an anesthetist in India, and then I moved to UK where I did my anesthesia again. And 1 year I spent doing pain research, which got my interest into chronic pain. And then I did advanced training in chronic pain. Then I moved on. Then I realized that ultrasound is very important. So I did a special training in ultrasound. And then when I came back to India, I realized that, oh, I get a lot of rheumatological and cancer patients. So I need to get specializations in these fields as well. So I've grown with depending on the needs of my patient, depending on my limitations. What I need to do is where I focus, and I've got the necessary qualifications on that. And if I was to summarize, what I would say is, what I've learned is when the patient says something to you, you need to listen to it. You may or may not be able to find a cause for it or explain it, but keep it in the back of your head. Someday you may be able to explain it. And that's what I've learned. What sounded really rubbish at one point, I could find uh, explanations for that later down in my career as I grew and as I evolved. And also the other thing I've realized is that I know so little. The more I read, the more I realize that I know so little. Like that, the small child which we discussed as first. Who am I to deny him? There might not be such strong evidence for burning the stenate ganglion, but that was a life saving for that child. So, and sometimes this does mean stepping out of your comfort zone, because if you remain in your comfort zone, that's not where the magic is, so you have to step out of it. This is where I work, apart from the Max Hospital, which was missed. So I thought I should add that. And thank you very much. And thank you for listening. I hope this has been educational for you. And this has added, some more information to how the pain specialists work and what all modalities or options they can offer when we're dealing with pain, where other people might just put their hands up. That's where we step in. But we step in before that as well in getting the right diagnosis and helping you solving the problems. Thank you very much.